Is there anybody that signed up for public comment? Do you know? Well, let me see. Sorry. Okay. All right, we do have a guest who wishes to speak today for finance, and Michelle Nichols will be acknowledged, so please.
Well, no, I just put it as just because I did need to make a comment.
Oh.
I'm talking at hearing no comment.
Yes, okay. So,
But I don't have a comment.
you don't have a public comment, okay. So generally speaking, what I think the plan is to try to have the public comments at the beginning, but if there's something more specific, then we definitely want to make sure it's addressed, but just want to make sure we have the public comment at the beginning. Thank you. All right. Next item, excuse me, on the agenda are the minutes for approval. If everybody's had a chance to review those, do I hear a motion to approve? So moved. Is there a second? Okay. Any question? All in favor? Aye. Motion passes. Okay. Next item up is Mr. Naramore for the 2025 budget update.
Yeah, it's going to be very brief, Madam Chairman. Just that we did receive from Metro yesterday the low cap, and I know that's a word that we use, but basically the charges for pension and legacy costs for the Bordeaux and Knowles facilities for next year in the budget. It is flat at $5.96 million, and then we will put that in the budget. That's the number we had holding in there, but it was confirmed early this week. And at this point, once we close February, assuming it's approved, we'll update our numbers there. And if there are any significant changes we need to make in the budget before we present to Metro next month, we will do so. That's it for budget.
Thank you. The next item is the 2023 audit update. And this was deferred. We had some rescheduling that had occurred. But one item I wanted to mention, at least for me historically, I have seen audit come through either the audit committee itself, which we don't have. Ooh, did you see that? All those years of softball and tennis. But I've usually seen it come through our committee first before it goes to the full board. I have an understanding that there have been some people who had preferred, I guess, maybe not to hear it twice. But at the end of the day, I do think kind of from procedurally, we as a committee should have an opportunity, and Christy Smith opinion here, to hear it, ask questions, really do the deep dive here in committee. And then that should be pushed to full board. So if you are comfortable with doing that, I would like to see that happen. So, but I want to get more conversation on that.
Comfortable as well. And I think the board, though they will also do their examination and ask questions, I think they do lend to us because they know we've taken more of a deep dive. So I think our due diligence would suggest that we should continue to do that.
Okay, that sounds great. So if you don't mind reaching out.
I will. Could I just make one suggestion? Because if we're going to do a deep dive, we may need more than an hour in advance if it's on the same day as the board meeting. And we'll ask Mr. Hunt to be here present, and I guess hang on, maybe we could put him early in the board meeting so he doesn't have to stay terribly long. Is that fair? Go ahead.
Could we start the board meeting at 2 instead of 3 o'clock to give time?
You mean the finance committee?
I mean, the finance committee, I'm sorry.
How long has his presentations in the past lasted?
Typically, David, he goes through all of his paces, required communication, right, and so forth. It's probably 20 to 30 minutes is his share of it. And then at that point, it becomes the committee asking questions of the auditor. So it could be up to an hour. He's quick. He's not going to take a lot of time to do his part, and he'll hand it out, and he'll have some overview comments. But I would say it's been 20 to 30 minutes in the past is his side, and then it becomes a question of how much time the committee asks of him and anyone he brings with him.
Okay. what are y'all comfortable with? 2:30? Okay, 2:30. I think, given the opportunity to us to ask the questions, read the material in advance, I've read it prior and actually had some discussion with audit, so I think it would be a nice opportunity for us to really get a little deeper, understand, and then for me, be comfortable with some actionable steps. And I know that there's some subtle nuances that would be helpful for you to explain as well. So thank you for being flexible to that. Okay, so that'll be a May item. Financial statements. Back to you, Bruce.
All right, month of February. It was a reasonably busy month inpatient. I know it's a 29-day month, not 31, so some of the numbers are down a little bit from the prior month, but admissions were basically at budget, 211. Observation visits were basically at the budgeted number as well. Patient days, and Christy and I were just discussing, we've done such a really good job with our length of stay in the hospital this whole year. A year to date, that's been a focus. So even though our admissions are at budget, our patient days are below, which means my inpatient revenue tends to run a little bit below budget, but it's a measure of clinical efficiency and moving patients through the process. I'm comfortable with it, but it looks troubling a little bit on the inpatient revenue side of the hospital if you just look at the raw gross revenue numbers. So average length of stay this year to date is at 4.0. It was budgeted at 4.6, and that's where we were last year at this same time. So a lot of favorable improvement there. Our emergency visits, they're pretty much flat this year compared to last year. They have not grown significantly. They recovered after COVID and sort of have reapproached some of their pre-COVID numbers, but we still like to grow that. We have capacity in there. You guys know we have a rehab. We'd like to do some rehab to the appearance in the ED. The service is good and strong. And I know we also have a program that we've started recently, basically for a no-wait ED. You may have heard it on the radio, but that's a way to encourage walk-in visits or low acuity patients into the ER that have coverage. Certainly we have capacity to do more in there. With that being said, we still generated 176 admissions out of the ER this month. And just if you look across for year-to-date emergency room admissions are actually up 10% from a year ago, even though our ED visits themselves are flat. So the ED is doing a pretty good job of taking care of patients and moving them through the hospital as well. Surgery volume was, again, steady but light. Our outpatient surgery bumped up nicely last month. I would note in the clinic visits, you see 3,979 visits last month. Last 3 weeks of February was when the Metro Clinic came on as part of the hospital. We have 2 primary care physicians there, pretty busy. So our numbers jumped from 2,800 last month to almost 4,000 this month. I think in March they'll be well above 4,000 because we'll have had a full month with that Metro Center clinic operational. So that's a positive, and that will produce downstream because that clinic actually has a pretty elderly population that they manage, which some of our clinics in Charlotte tend to have a lower age demographic. So the older the patients that they take care of, typically the higher the utilization of those patients. So that's a good thing for the hospital. Cardiac cath lab was down last month. It's been down a little bit last couple of months. I think Dr. Akama was out for a week. And so that obviously affected the volume. Deliveries have been down the last, say, 3 months or so. Last year, there was significant growth in that service line, but this year to date, our deliveries are actually down about 17% from a year ago. I can't speak to it, but the numbers are just down generally in the OB section. Case mix was up a little bit last month, which is a good thing. And then we would go on to the financials themselves. As I told you, the inpatient revenues for the month were below budget, roughly 14%. That's basically related to the length of stay because we hit the budgeted admission numbers, basically. So that's why that is a negative 1.2 million variance in the gross revenue line. Outpatient revenues were right on budget, slightly better with the addition of the Metro Center Clinic. They produce about $250,000 in a given month of revenues. As far as deductions and so forth, we had a reclass of some bad debt stuff, so you see a credit in there. And Christy and I talked about it before the meeting. It's just a mass reclass of patients that we believed did not have an insurance source. Turns out many of them didn't have a TennCare opportunity. So we just have to put them in the right buckets and update our model. So it just moves some of that money from bad debt into uninsured discount this month, and some into charity as well. But still, even with that, we had a good net revenue month at $5.5 million. We were about 6% better than the budgeted number. We also had a good month we received a state supplemental payment this month. And as well as you guys know, we got a larger supplemental pool payment at the beginning of the year, and we're amortizing that $13 million monthly. So we're well above budget on our other revenues for the month, and that really helped us. So total net revenues, $3 million ahead of the budgeted number, and we needed all of it because our expenses were particularly high this month. Our salaries were up even above last month with a 29-day month, and then our contract labor continues to be challenging. We have knocked down the number from about 70 vacancies in nursing to about 61, but the challenge is not just bringing them on, but keeping them here. And I say that with Dr. Hudson and Christy because I have a nurse daughter who also thinks it's really lucrative to go out and work as a agency nurse, but I have so far convinced her not to do that. Anyway, most of our expenses are in line. You'll see an odd credit in the contract services versus physician services. That's me making a correction. We had been booking some radiology coverage into contract services, and to me, the radiology contract is a physician service, and so we just reclassed that, caught it up for the year to date. But all in, those numbers actually line up with what they should be for the month. The other is repair and maintenance. We did have two pretty significant major repairs. One we had initially capitalized, but on further review, I didn't think it met, so we took two six-figure repairs into other expense this month. So all in, our expenses were almost $2.2 million higher than our budget for the month, driven by salaries, contract labor, and really the repair and maintenance and other were the variances there. Still, at the end, a $327,000 positive margin, so we beat the budget by $900,000. And for the year to date, the hospital has a $4.7 million positive margin and about $9 million ahead of budget, and similarly a little bit more than that ahead of prior year at the same time. So positive, good February month. Questions?
See that net operating is up like 9% over last year, which is terrific.
Yeah, I mean, that is good.
More to do with percentage of people who are insured, as opposed to volume.
It is mostly better payer. You know, we don't talk about it a lot in detail, but, part of the business plan of setting those clinics off property is it allows us to have a fully insured population of patients that then get referred into the hospital. All of the indigent or charity care for the most part is performed here at our clinics at this location. But when you open it at Metro Center or at Bordeaux, those are all insured populations. So when you talk about 60 or 61% of our patients are insured, it keeps going up because we're building more and more of those insured patient populations. And then the trick is to get them comfortable with coming to the hospital when they need a surgery or something like that. That is the plan, the business plan.
But uninsured patients are free to come there.
Uninsured patients are free to come here. We don't typically schedule them at the insured clinics off-site, but if if the doctor that they usually see that's here is at one of those sites on a given day and they have a follow-up, we see them. Yeah, absolutely. Yeah.
And, on the statistics,
Mm-hmm.
we don't see, number of clinic visits.
You,
Or at least I don't know.
no, you do, that 3,959, did you see that?
The second statistic.
In the far left column? It says med-surg clinic visits. It probably should just say clinic, but it's listed as right in the middle of the page on the left, 3,979.
Oh, yeah, okay.
Right, that's clinic. That is clinic visits.
Okay, so here today, we're about the same.
Yeah, we are. But like I said, when we picked up that new clinic, it's going to make a big difference. Sorry.
Yeah. Okay, I was just trying to get an idea of the payer mix difference between the hospital and the clinics. So you explained it. Thank you.
All right, the next item on the agenda is a revenue cycle. Dr. Blackledge.
Hello, thank you, Chair. Yeah, we've got it up on the screen. So cash collected for the month of February, we're at about 5.5 million posted to the bank. I do want to share, we have a couple of leaders, which is, I've got 3 team members in the room, so I want to make sure I point them out. Over your shoulder, Martin, right behind you is Jessica Crabtree. Jessica runs our revenue integrity. Faith Reed. And Faith takes care of all of our patients, make sure they're authorized so that we can get paid, handle all of that administrative burden type paperwork that is challenging for us. And then Mark Chase on the back end, handling the patient account. So I want to say kudos to this team because they make these things that I'm about to cover happen for us. And that's real important. So what we've been focusing on is connecting our issues. So what are our issues? How do we categorize our issues? How do we log our issues? So this team has graciously put together an issues log. It's in its infancy stage, but it will help us continue to drive process improvement, and that's part of our goals. So the next step, they'll be grouping these items for correction, education, whatever is needed, and they'll be reporting back. So these are the cadence of activities that support our net revenue improvement, cash acceleration, and the integration of education needs, other needs for our revenue cycle team members. And that's kind of the synergy and the focus of this team. But you guys can see the trajectory and know that we do have headwinds, but at this point in time, we're in the right direction. So I want to just make sure I share that piece of it. We can go to the next slide. And so the next one is really about the unbilled inventory. And so there, over a 13-month period, we're at 4.22 days, which is exciting for this point in time. This is what we must work at daily to ensure that we can get the cash flowing on the back end and continue that cash acceleration. You can go to the next one. And then the last slide, you can see some of the impact of Faith and team and Jessica and Mark working together. You can see as of November, you see the trickle down over December, January, and February, really focus on the denials management. And so this is what we mean when we talk about our business processes, how we pull things out, how we view them with a laser eyeball, how do we correct those, and how do we make sure that the items that we have corrected are continuing to work for us day over day. So for me, it's every hour, it's every day, it's every week, it's every month. And I've had 6 of those. I think I shared that earlier. And I asked myself the same question at the end of each one of those periods. Do I maintain? Do I change something? Those are the critical pieces for me, and it is the it. Do I maintain it? Do I change it? Every day my it is different. And a lot of times my it comes from the team members that I just named, because that's what we have to look at, and that's what we have to focus on for the financial viability of our organization. Yep. So that's it for me. I'll entertain questions, but we're going to continue to move forward. Thanks.
Great work.
Thank you.
Chair, could I just interject something? I don't, and maybe Ms. Blackledge would speak to it, but there was a significant impact to all hospitals, basically, revenue cycle functions. You may have read about it, Change Healthcare had a cyber attack. They're owned by United, and it's had a significant impact, not just on us, but pretty much every hospital in the United States, because Change Healthcare owns 5 or 6 major sort of claims processing platforms around the country, and it trickles down, it affects us,
Right.
and it will affect us. So it may not have a huge effect on March, but they shut down a lot of platforms at the end of February. They started bringing parts back up in mid to late March. But you could imagine, I don't know how many, 4,000 or 5,000 hospitals in the United States, and most of them probably couldn't get out their hospital claims for about 3 or 4 weeks. And then just the amount, and Change as an intermediary before your claim gets to basically any healthcare payer. And then they're also the return, once the payer processes your claim, they're the one that actually oftentimes is the actual payment platform that sends that payment to and processes accordingly. They're also the claims data clearinghouse for most of the claims in the United States. So it's going to have an impact on our cash collections. I've already seen it. We've seen it. She's seen it. You haven't seen it. You might see a little of it in March, but I know you're going to see it in April. So I'm going to have her
jump
speak to
in,
that.
Bruce,
Yeah,
on
go
that
ahead.
one. So what Bruce is referring to, he talked about the Change cyber attack issue. And as you guys have well known, if you just simply watch the news, read the paper, read a association periodical, you will see the cyber attacks. So we had a cyber attack with Change. The challenge with Change is, and we'll probably see this in the FTC later down the line, is they have their hand or a product in every part or piece of the revenue cycle. So when you come in and you are a patient and we verify that you have insurance and we verify that effective date so that we can ensure that we've got a pathway for our reimbursement, they have that platform. So that's eligibility. If we receive a payment and the payment comes in, they have that platform. So that's payment. So they touch every part and piece, probably about 6 different platforms. Could be a coding platform. So part of what they do is take our data and they exchange that data into code sets and then send it to the insurance provider, because we do everything in codes these days. So even if it's a name, it has to be, translated in that way. And what that is meaning to us at this point in time is probably about $600,000 shy or short in our current month. So this current month of April. Now, what does that mean for us putting cash in the bank? What that means is there will be a delay. So when we focus on, or what we focus on, is cash acceleration and that revenue improvement. Right? That's our intent. That's our goal. That's what we strive for every day. However, when you have a headwind that kind of slaps you, hits you in the head, wakes you up in the morning with the cold water, if anyone is taking a cold plunge, and it alerts you that we've got a problem. And so our team quickly assembled. They have a plan in place. They're executing on their plan. They are monitoring the reports. They probably get tired of me reaching out to them. I know, Mark, what does it look like today? I haven't gotten my snapshot. So I have that on Teams every day. Jessica is running with our vendors, Parallon, just making sure that we get all the claims out of the door. What does that look like? Can you send me your file? We need to try to figure out how to reconcile this back to our department charges. So there's a lot of moving parts, but as best we can execute daily and stay ahead of the pack. I'm in constant contact with my peers and colleagues around the U.S. This has been experienced across the U.S. There's not anyone left out. But we're in the best position we could be in right now. Yeah. That's our job. It's challenging, but that is our job. And we're going to do the best job that we can do for you every day. As we said, every day, every hour, every week. Do we what? Maintain. Do we change?
So this is just a delay.
Delay.
So we will see it, and so longer term, we'll see this money
Yeah.
coming back in, so it's
It's
just.
money due the organization.
Yeah.
The money is coming, it is a delay. And so when you have those delays, it's, how do you address the delay? No one wants a delay, right? We provided the service, and we provided the service in good faith, understanding that we had the authorization, insurance eligibility, correct, everything that we needed to be reimbursed. Yeah, we've already provided the care. It is a delay.
So do you have like an estimated time frame in which to be?
We've said 30, 45 days. I'm looking in the corner. That's what we've said, yeah. Because
So maybe June-ish, we may.
maybe June-ish, we'll
may
see it better.
actualize in the numbers.
Right, and we have to recognize too that when we have a company such as Change Healthcare that have their hands in every part and piece, and this is a cyber attack, they're probably working the best plan that they can. And so what will work, sometimes we don't know until they try and make that work, right? Because there's limited time for testing. And so during this time period and this shift of expectations, you have to really roll your sleeve up and just get in there and just do it. Sort of, I borrowed that from the Nike team. You just have to do it. And then so what we have for us is, what is our escalation path? Something that we often talk about. How do we escalate? How do we quickly get on the phone? How do we solve the problem? And so our goal has been just to train people in solving problems. Yeah. Yeah. Good question. Thanks.
Bruce, you're good with that? We're ready, budgeted, we can handle it. Okay, great. Yes. The next item is the Nalco Water. Dr. Mark Brown? Yes, ma'am. Oh, yeah, sorry. Yes.
So moved.
Is there a second? Any discussion? All in favor? Aye. Motion passes. Sorry. All right. Dr. Brown? I was going to say, let's go out of order then. Let's go ahead and move on while we're waiting on him to Oracle. Back to Bruce.
Madam Chair, just for everybody to be aware, we did defer the space labs until next month. Okay. Yeah, this is an Oracle agreement. It's a $50,000. We got to build 2 interfaces to our multi-view, which is our ERP, our general ledger, financial materials management package. It's a partner of Cerner, but it is not a Cerner product. But because we are going to use Parallon and CareCloud and not use Cerner's built-in platform that ties to multi-view, we actually have to pay for 2 interfaces to connect our patient billing, our charging, our payments and adjustments, our refunds back into the general ledger in multi-view. And it's about $50,000 is in scope for the professional services. We don't think there's going to be any travel, but we did put 15% in for travel just in the event that someone had to come on site. So it was not in scope when we put the Cerner contract together because we thought we were going to use the Cerner AR process and that Parallon would work in the Cerner AR system. And then we ultimately learned that Parallon drew a white line and would not work in an alien system. It had to be in theirs. So we're having to basically create interfaces back into our GL for both CareCloud and Parallon for revenue cycle, refunds, et cetera. So that's what this request is for. This is a one-time, right. This is a one-time build the interfaces. They may have to be maintained at some point in the future, but it would be de minimis.
Any other questions? I know you and I spoke a little bit about the technology piece and how some of these, during our individual meeting, of kind of creeping in and not necessarily having the maybe knowledge and or not budgeted, I guess is what I'm saying. This feels like that. Would you agree with that? And I guess, how do we keep from, 50,000 is not a ton of money, but how do we keep from having some of these issues maybe crop up?
Yeah, I'm just going to say, when you do a project the size of what we're doing with Cerner Oracle to replace our EHR and our basic financial systems, we put it together 18 or 20 months ago when we sort of made the choice between the last two platforms. And then it was what we thought we selected was turned into about a 220-page, very detailed sales order. And we find occasionally there are certain things that got missed in that process. This one wasn't really missed. It was just we believed that Parallon would do their work like they do for us within the Cerner AR system, and they basically told us from a compliance standpoint they could not do that. They would not do that. So when they made that decision, it was after we had already chosen Cerner, and it was not, Cerner didn't know about it. Parallon probably did, but maybe we didn't ask the question the right way. So in order to have payments and adjustments and refunds and so forth flow back into the general ledger from the Cerner AR system, we have to build these two interfaces. It's just, we don't really have much choice here.
Cerner work with Parallon and other hospitals, I would think.
They do, but no two, we're Cerner Community Works, and Cerner Community Works is a shared server sort of network. I don't know if there are IT people here in the room, but that's what makes it so different. I had Cerner in a hospital previously for 10 years, and my Cerner was just my Cerner. The Cerner that we have is called Community Works, and so we're in with a group of about 40 other hospitals, kind of similar size to us. It's a much more controlled environment where the way the systems work is not easily changed by the client unless the other 39 clients also agree to make that change. That's why it's a little bit more complex than maybe it would have been if we were a big hospital that had our own Cerner Oracle Health platform.
And for being a part of that group, it's discounted.
It is. The pricing is less because you basically get, I hate to say one size fits all, but you get about 80% of the functionality, and the workflows are similar if you go to any Community Works platform. And then we have very little ability to deviate from that. And if we do, the only way we can deviate is basically if the other cadre of hospitals agree to that change. Some of them will be regulatory changes that we'll all have to take on, and so Cerner will make those changes. But if we just want to do something different because that's the way we like to do it with pharmacy or whatever, we will not have that ability to do that going forward. So because of that, there are some limitations, and we've got a map to the way Cerner does it back to multi-view. We don't get to pick and choose as easily, if that helps.
So I know that this wasn't budgeted for because you didn't anticipate this expense, but have you allocated or determined where these funds would come from in the budget? Is it just general operating expenses, or is there a bucket?
Yeah, right now, Dr. Hudson, they will just come from operating funds, but the 4% money that we occasionally get, we request from Metro, that 4% money does not specifically have to be for capital. Whereas, the $7.3 million that we got, that is capital, and it's focused on capital. But something like this would actually be eligible for 4%. I'm not going to say we would apply for it because it probably would not be popular compared to a fire truck or something else that Metro uses 4% money for, but it is eligible for it. So right now we would fund it out of operations. We're trying to get that system up and operational and functional because our current system is limited, and there are risks with it as well. So,
What's your implementation timeline on this?
this will be short. I mean, the Cerner Go Live is still December 16. This build will be fairly short. We just have to get the two CareCloud and Parallon to give their specs. They'll build the interface. I think it'll be done in 45 days. I don't think it'll be terribly long.
Great. Any other comments, questions? Okay, great. If so, I will entertain a motion to approve the Oracle America Inc. professional service contract. Do I hear a second? Any discussion? All in favor? Aye, motion passes.
Thank you.
Thank you. Do we want to keep going with the Oracle America? Okay. We will move on to the Oracle America, Dr. Felicia Fair. Thank you.
Good afternoon. I'm Alicia Malin Fair, and I'm the Chief Population Health and Research Officer. I do want to point out two subject matter experts who have been working with this contract for the last 18 months, and that would be Kalela Hackett over here, Senior Director of Population Health. And we do have an informatics expert in the room, and that is the Director of Clinical Informatics. That's Brandy Plunkett over there. So this is also a phase 2, so it wasn't originally considered, but it really will synthesize and harmonize the data. These are 4 different modules that would sit on top of the existing medical record and to harmonize quality, billing, our research feasibility, and reporting. 4 different modules. You see in your agenda that we were negotiating beyond the one-time cost for professional services, and because of our excellent relationship with Cerner, they have offered price protected fixed 18 equal payments of $23,155 per month beginning March 1st. So that is new. That is not reflected in what you see in front of you because that is a very new development. Of course, we also have travel, but that would only be used if necessary for at-the-elbow support. And there are also reoccurring fees because having interoperability of all of these systems is necessary considering the legacy and the current data that we have.
I'm sorry, I may have missed this. Is this replacing something else?
It's enhancing what's
It's
existing. And, you know, I've been here 2 months and I can attest that from the clinical research realm, which falls under population health, we have such incredible expansion for the clinical trials that are being attracted here from pharmaceutical companies, which requires all the databases coming together to look at the inclusion and exclusion criteria. In the last 2 months, we've had interest from 4 different pharmaceutical companies and upwards of 6 studies, all within oncology. So we really need everything to be catalyzed to generate these research feasibility reports, not only for Nashville General Hospital, but to work with other institutions that want to partner with us to conduct population health research.
This contract duration is for how long?
The contract duration it's quite extensive, and I would ask either 10 years? 10 years.
So I just want to be clear about the cost. So you're asking, this is the $479 for one time?
This is, well, the payments are, of course, for the professional services at $400,000, the $16 there. That's broken up. That was not reflected in your initial agenda. So that when we said there the one time, this is actually that 18 payments, and then the reoccurring payments stand at that 19,000 that you see.
So it's actually, you're dividing it out. I just want to make sure I'm clear. $23,155 for consulting,
Yes.
reoccurring $19,818, and all of that for 10 years.
Yes.
Okay, so I just want to be thoughtful in understanding this because I don't come from a medical background. So I just want to understand, can you help me maybe dumb it down for me and explain what this actually does?
Well, you know numbers, so I don't have to dumb it down. And I think that's a great request because as far as medical field, yes, but also this also allows us the time to test the environment across all of the different workforce in the hospital that are not, they work in the community. We have eligibility for studies where we work with some of our population health and faith communities. We also are working in nutrition and services to be able to look for individuals who, through care management and through community care team, are eligible for our food as medicine programs. So we need the support of Cerner and knowing that they are working with us over these 18 months to price protect this before Oracle acquisition. These dollars are needed for these enhanced programs to talk to each other, to work in an interoperable environment, to generate and be facile in the reports, to assess quality, to meet reports for local, federal, and other. Yes. At-risk patients, identifying them, and to identify them and to be able to provide that information to payers.
I also I want to just interject. This is population health management. As we are engaging in value-based care, you understand the terminology behind value-based. You've got to have the mechanisms to be able to track and monitor all of that activity. Also, our care management program, which is essentially tracking, monitoring high-risk patients and being able to actually pinpoint, that's major cost avoidance. The value-based care remuneration is really being rewarded for being able to track and monitor the activities and to submit data and extract data. So it's a lot of interactivity that we have to have in order to be able to execute at that level, which we don't have now because of the legacy system that we have in place.
Correct. I'm happy to join in a little bit further too, but for the models that Dr. Fair and her team need to provide the care coordination, both financial modeling and the care modeling, this enables her team to pull in that information without having to go spreadsheet by spreadsheet. All of the algorithms that are associated with population health and our ability to manage our population and to provide that information in a reportable, usable arena.
And not all of these are medical. Social determinants of health are non-medical. So those are things that would show the characteristics of a patient that would be at risk and then be able to navigate them through all the services offered at Nashville General Hospital.
I think when you look at this on the surface, you see what appears to be a high dollar cost. The return on this with what you're able to do and what you're able to generate, actually this is a drop in the bucket.
So the 237, that's a per year recurring.
For the reoccurring costs, yes.
So that's the only yearly cost. The 416 is single upfront.
It's actually broken down into payments, which that information is not on your paperwork, and I'm sorry that this actually came through from Cerner at 18 equal payments of $23,155. It's not the one time that we had negotiated and just received the contract for the 18 payments, not
So
one time.
what will be the yearly cost over the 10 years of the contract? That's what I'm trying to get at.
Yeah, that was 18.
So 2.849, is that right? Is that what we're really talking about?
Yes.
'Cause that's what I'm trying to.
Yes.
It feels not clear. That's what's clear. It's basically 237,817.56 times 10. That's per year times 10 years is the contract, plus the one time, which is divided over 18 months.
Yes.
So they can cash flow it better, I think
Okay.
is the game plan. And I didn't get into the nitty gritty detail of this, but I guess to me that's a big number for a consulting. I'm not saying it's not needed, but I'm just approving something for a 10-year contract feels like a long time to me, especially not knowing the ultimate outcome. And in a 10-year time window, would it make sense to renegotiate a contract? Does it make sense to, if we're unhappy, to be able to get out of the contract? If it's a consulting services, or is it actually a deliverable? I understand, I guess I'm still struggling with what we're getting. I understand the game plan, and I understand the outcomes that you're trying to get, but ultimately, I don't really still understand the deliverable. Does that make sense? Am I missing?
No, I feel a little fuzzy too. I was thinking, okay, so this is a database or server is what I'm imagining that helps. Does it help
I wouldn't say a
correlate
database
data?
or server. So I would say we
Okay. Let me
reporting.
can I complete
Yeah.
my thought? So that's not what it is. So I'm further confused, but it sounds like a way for if you're applying for a grant is kind of what I'm envisioning. And you need to be able to access data as it relates to a certain population within our community, as it relates to social determinants of health. This is a vehicle in which you would extrapolate that data to be able to apply for grants and or have
feasibility
research
studies,
or
right.
publish whatever. Is that correct?
That is one part of it, but that's just the research part of it, and then there's also the care management, the quality, and the billing part of it as well.
Okay, billing.
And for example, the care management piece, this tool will enable us to direct the patient in instances or populations of patients for the right care in the right place. So overutilization of the ER. Dollars that
Okay,
could
now,
be
okay.
saved. So just want to kind of make sure I share.
You're able to track
And then-
patients, is that what you're saying? You're able to track them and identify?
I can provide a little bit more clarity because I've been involved in this full project along with IT in this project. So I'm over population health management. So I have analytics team and I also have the community care team, which is our care management program. What these platforms allow us to do is to track patients. Our case managers that are part of our care management team can follow these patients, create a plan of care, try to meet their goals with that patient over time. It is separate from the medical EMR. So this allows tracking for our care management program. Also, what it will support is our food pharmacy program. So patients that are part of that care management program will likely be part of our food pharmacy program as well. So we can track all of that information, track and trend all of that information within these platforms as well. The major cost is the EDW, the Enterprise Data Warehouse. That is where that is where our analytics team is at the forefront. What the EDW allows us to do is to consolidate information from both of our legacy systems, so that's Paragon and ECW, and then also bring together our new information from Oracle Cerner. For my team, as we code, that's difficult to do as you keep having disparate systems. What this does is brings it together, and then we are able to query one system for all of that information. So what it'll help us do is be quick. So if there's reports, we're having feasibility study requests and all of these other things, it'll allow us to be quick. It'll allow us to not have to hire as much staff because we're agile. We're able to to extract that information quicker. And then also within the EDW is Tableau, which also probably adds to that. And so that also helps us with our visualization and projections as we're looking at that going forward. So the data supports all of the efforts within the hospital, which is a part of this proposal. And then the population health, the care management part, the chronic condition management, social determinants of health will help support our care management program.
And I do believe that this is a requirement of CMS to participate in the value-based care component of it.
It'll support a lot of things that we're trying to do with quality improvement. We're involved with the patient-centered medical home. It'll help for us to meet all of those requirements.
Did you get other bids from other vendors?
So we did for the care management tool, Eye to Eye, which is based out of Franklin. We met with them several times. What discouraged us from moving forward with them is that there's a unidirectional interface. So the information from Cerner can go into their program, but it doesn't do the reverse. And what we want to get away from is the disparate systems, which we have right now.
The unidirectional component, because we need the systems to all talk to each other, and there are 4 different ones that are in this proposal.
Yeah, and I mean, cost-wise, I don't think it was much different. The major cost for this proposal is that enterprise data warehouse. But again, it supports all of the different areas. We support quality, we support finance, we support revenue cycle. Our team, supports everybody in the hospital. So it would definitely help us be able to do that quickly. And also our partners outside, research and all of that, we're helping with that. So it allows us to be quicker and agile.
Is it fair to say that some of the neighboring hospitals probably have these types of systems and you all have been at a disadvantage for a while not having that?
Yes, bigger hospitals definitely have an enterprise data warehouse. We have in the past, with the disparate systems we had to try to combine them and make it a little bit easier. We had somebody in-house who was working to create one, but it's a lot of work. It's very technical, and we don't have that staff member any longer. So what we can add to that is very limited, but we're talking about adding a completely new system. That is, and they're not, their stuff is proprietary, so they're not going to give us that information, right? And be able to help us add that to our
And how would this
databases.
alleviate the coding? Because you talked about this too as something that would be advantageous to have. So when you have to, the coding that would be learned using these systems versus continuing to do what we do here with this system.
Yeah, I mean, with the implementation of this EDW, we would have to, as a team, right now we were using SQL Server, so there's a coding language that's associated with building queries for to be able to extract the information out of these systems. So right now we're using SQL Server. With the Enterprise Data Warehouse, we would have to learn Oracle Cerner's coding language, which is DA2. And so we're trying to prepare for that transition as well, and we're trying to engage in trainings and such before we go live with these systems. So it's important that we kind of have this in place so we can go ahead and start the building and the training. There is a portion of this that there's a lot of building that goes into the first part of this. They have to understand our legacy data and be able to kind of match it as best as they can with their own warehouse. And then again, we have to figure out the ins and outs and the differences between the two systems. So, the three systems.
I think the question is really more or less, is this community standard? And we're trying to get to community standard.
Since it's a 10-year contract, which we're not used to hearing, is there an opt-out if we decided in 3 years to go a different direction?
I'm not sure about that. Brandy, do you know anything about
Can I
that?
just say, the Cerner contract is a 10-year contract. The main EHR contract is a 10-year contract, so I think this is just mapping with that. So, but I don't know. Brandy may know if there's an exit in the main Cerner contract.
You can come up here. Just push the button.
So there is an exit in the main contract. I don't remember the terms. Obviously, there's a cost and a penalty that comes along with it. So I'm sure there's one in this one as well, but there would be a cost and a penalty associated with that as well.
Is this for consulting, or is this for actually a system? Like we're buying hardware or software?
We're buying the platforms that work with the Community Works platform. So they sit on top of Community Works. There's 4 different platforms.
So we're buying the platform, which is that the EDW that you're talking about?
So the Enterprise Data Warehouse is one of them.
Social determinants of health.
They have different names on here. Population Health Management and Care Management, and then the Determinants of Health. Those are the 4 that would be covered under this proposal. So the reason it's being brought up now, as Dr. Fair had said in the beginning, this was always going to be phase 2 of the implementation of Cerner. So this wasn't brought up in the initial discussions when we were talking about Community Works. So now what we've been doing is vetting this and talking with other vendors, working with Oracle Cerner to try to get the best pricing that we can. And then I just wanted to clarify too, with the professional fees, that is a one-time fee. So that $479,800, that was before it was going to be required for us to pay that at one time. What we've been able to negotiate is to have that broken up into 18-month of payments. So make it a little bit more digestible for us. The $19,000 in the monthly fees is going to cover the platforms each month, but there's a monthly charge to each platform. So that's what a 10-year payments would go off of that $19,000.
So we're paying Oracle, or employees at Oracle, I'm just trying to make sure I understand, the $479 ultimately, cash flowing it the certain way through 18 months?
They will help us build the platforms and get they support the projects.
Okay, so I just want to make sure I understand. So there's no reason in theory, or is there a reason maybe, if we got into Dr. Martin's point, we pay the $479 in 2 years after the fact, we're not happy with anything, or we're not happy with the product. I would be very interested to understand any out clauses that we would have, because again, it is a 10-year contract. And if we have that with Cerner, it makes sense, I think, to have it in this contract. And then two, I just, it's just a big number. So again, not saying it's not worth it. I just want to make sure that we all are comfortable with, understand it, because I think as you've heard us, we've struggled a little bit with trying to understand it, and then the cost associated. So.
It's, I mean, the EMR, you know, it makes total sense to have a 10-year contract. You're not going to change that again, hopefully, with the cost, financial and otherwise. I just don't quite understand if this falls in that same category.
These are platforms to support the EMR. So, Brandy, you can speak more to this piece.
So I would just say exactly that. It's going to sit on top of Cerner. We would not be interested, and I think that Kalela and her team has done her due diligence in looking at other options that would sit on top of Cerner to provide the same information and the same data that we're looking for and the same data mining. And what we found is that at this point in time, there's not a better product out there. This is worked by the Cerner team. This is what is going to help us get to the next step. So with it sitting on top of Cerner, in 2 years, if we're not happy with the product, we're going back to Cerner saying, fix this, make this better. We're sitting on those boards and those teams to tell them why they haven't allowed us to reach that next level. We're not bowing out of the contract because another company is not going to allow us to go in and make changes without buying more interfaces, more software to help interconnect Cerner. So that seems disconnected. There's, in my mind, if you're buying a product that's supported by Cerner, is bidirectional, sits on top of Cerner, the information flows back and forth. You're not piecemealing it like we currently have now. There's no reason to think that in 2 years, 5 years, or 7 years, we're not sitting at that level with Cerner trying to make the product better.
Good. I think it'd be great to have that explanation when we, up front when we present this to the board, and maybe even, what the penalties might be for changing.
All right. So are we comfortable making a motion?
So moved.
Okay, is there a second?
Second.
Any more discussion? The motion to approve contract for Oracle for the healthcare management consulting. Is that? Okay, so any discussion? All in favor?
Aye.
Aye. Motion passes. Okay. Okay. All right. So we'll circle back to Dr. Brown on Nalco Water.
Good evening. This contract is a 3-year contract. It's $32,953 per year. And this is needed to clean instruments and most of all the robotic equipment. So we've talked about this before, about the water source and what we needed in order to even just clean our OR instruments before. And so this contract is for that, to make sure that we are cleaning and disinfecting the equipment appropriately. Also, it helps with, they do testing throughout the system for Legionnaires where we have low usage of water. So they go around the facility to make sure that we don't have any Legionnaires in the system as well. Happy to answer any questions.
What was it that we approved last month?
We talked about the water source before, I think about 6 months ago, that we were going to need this here piece to go with the robotic system.
Okay, thanks.
This is a new vendor and a new contract?
Yes, it was bidded out. We had 3 vendors, and they were the one that we chose as the facilitator for those for the water source.
Okay. Is there a motion to approve the now water service contract?
Second.
Okay, great. Any question, discussion? All in favor? Aye. Motion passes. All right. With that, we'll stand adjournment. Motion to adjourn.